Hello everyone. Today I'll be taking another VivaLive session with QQSphere on the subject of physiology and on the topic renal system. So let's start.
Welcome. We'll begin with our examination now. Please tell me about the main forces that determine glomerular filtration rate. This information is not medical advice or diagnosis. See a healthcare professional or seek care.
The main forces that determine glomerular filtration rate are also called Starling forces, which is the net filtration pressure. It contains two forces under it. Forces favoring filtration, which is glomerular capillary hydrostatic pressure, and forces opposing filtration, which is the Bowman's space hydrostatic pressure.
You've mentioned two important forces. Are there any other forces involved in opposing filtration, particularly related to the plasma proteins? And how do these forces interact to give you the net filtration pressure?
Can you explain, please?
Certainly. Besides the hydrostatic pressures you mentioned, there's the colloid osmotic pressure created by plasma proteins in the glomerular capillaries. This force tends to draw fluid back into the capillaries, opposing filtration. So the net filtration pressure is determined by the difference between the forces favoring filtration, glomerular hydrostatic pressure, and those opposing it, Bowman's space hydrostatic pressure and capillary colloid osmotic pressure. Are you clear on this concept now, or would you like me to touch on renal clearance as well?
Let's talk about renal clearance as well.
Very well. Can you define renal clearance and explain why it's clinically significant? How can we measure glomerular filtration rate using the clearance of a substance like inulin?
Renal clearance is the volume of blood plasma completely cleared of a specific substance by the kidneys per unit time. It serves as a vital marker for kidney function and drug elimination determined by glomerular filtration rate, tubular secretion, and reabsorption. The clearance of inulin is the gold standard for GFR measurement because it is freely filtered but not reabsorbed or secreted.
Excellent. You have clearly defined renal clearance and explained the significance of inulin. Since measuring inulin clearance is complex, what's a common clinical alternative used for estimating GFR, and what are some potential limitations with that method?
The most commonly used in clinical settings is creatinine to estimate GFR, although it is slightly secreted.
That's right. And what are some factors that could affect plasma creatinine levels, potentially leading to an inaccurate estimation of GFR with this method?
In case of burns on the patient and in case of dehydration or kidney damage, there can be an increased and inaccurate estimation of GFR.
Those are relevant factors. Changes in muscle mass or diet and certain medications can also affect creatinine production. Now, let's switch gears a bit. Can you describe the process of concentration or dilution of urine, particularly how the countercurrent mechanism works to establish the medullary osmotic gradient?
Yes, the countercurrent mechanism is a physiological process where fluids flow in opposite directions with adjacent tubes like a loop of Henle and vasa recta in the kidney, creating a high osmotic gradient. This enables to reabsorb water and produce highly concentrated urine to conserve water and maintain electrolyte balance. The kidney urine concentration happens when loop of Henle in the medulla increases interstitial osmolarity, which allows water to be reabsorbed from the collecting duct.
That's right. And how does the countercurrent multiplier specifically generate that high osmolarity? And what does the vasa recta do to maintain that gradient? What roles do urea and transport proteins play in all of this?
The vasa recta are blood vessels parallel to the loop of Henle that transport reabsorbed water and solutes back to the bloodstream. And
Yes. so they help maintain the gradient. What about urea and the transport mechanisms in the loop of Henle you mentioned earlier? How do they contribute to the gradient?
I don't know about this. Can you explain, please?
Certainly, the thick ascending limb of the loop of Henle actively transports solutes like sodium, chloride, and potassium out into the interstitium, making it concentrated. Since this segment is impermeable to water, that increases the medullary tonicity. Urea also plays a part by recycling from the collecting ducts back into the medullary interstitium, further enhancing the gradient. Are these concepts making sense now? Perhaps we could move to acid-base regulation next?
No, thank you.
Understood. We've covered glomerular filtration, renal clearance, and the